Let's join Dr. Gary Levine for a discussion on renal disease 2.
As we mentioned during our last lecture, if you've experienced acute kidney injury, you're at greater risk for chronic kidney disease. So here you are. We're going to talk about chronic kidney disease. And I certainly hope that everybody has a lot of liquids with you, because this really is a pretty dry subject. Thanks again to Dr. Fraboni from the University of Minnesota. And we're going to talk about chronic kidney disease. We're going to mention some of the guidelines that come from KDOQI, the National Kidney Foundation's Kidney Disease Outcomes Quality Initiative, updated last in 2012. It is not a radio station west of the Mississippi. It's the National Kidney Foundation. 27 million adults have chronic kidney disease in this country. Over 500,000 treated for end-stage renal disease in 2007. Our incidence and prevalence has increased dramatically over the past 25 years. CKD is associated with mortality, morbidity, and increasing healthcare costs. Those patients with CKD have increased risks of cardiovascular disease and stroke, and that's how they die. What are some of the risk factors for CKD? I've listed them in alphabetical order here for you and underline the ones that are really important: diabetes and hypertension. Diabetic kidney disease accounts for 39% of chronic kidney disease, and 2/3 of that or more is type 2 diabetes. Of non-diabetic kidney disease, 25% of that is vascular, mostly hypertension. 18% glomerular diseases, cystic diseases, tubular interstitial are far down the road. So where are you going to make your greatest impact? Diabetes and hypertension. What we see mostly in our offices, diabetes and hypertension. The causes of CKD that lead to end-stage renal disease and transplant: diabetes and hypertension. Again, chronic pyelonephritis, polycystic kidney disease, pyelo, stones are further down. So our first question for you: stage 4 chronic kidney disease is defined as an estimated GFR of which of the following: 60 to 90 mLs per minute, 30 to 60, 15 to 30, or less than 15 mLs per minute. And you have voted for C, 15 to 30 ml per minute, which is the correct answer. So we did very well here. How do you define chronic kidney disease? By KDOQI criteria, that's kidney damage lasting more than 3 months. By kidney damage, we mean structural or a functional abnormality, maybe with or without a GFR, if being decreased. If the GFR is normal, typically the patient has persistent albuminuria. Also, anybody with a GFR of less than 60 is chronic kidney disease with or without actual structural kidney damage. So either or will get you chronic kidney disease. Chronic kidney disease is defined in stages 1 through 5. Stage 1, a fairly normal GFR, but there is persistent albuminuria. Stage 2, the GFR is 60 to 90, again, persistent albuminuria. Stage 3, now divided into 3A and 3B. 3A, GFR is 45 to 60, stage 3B, 30 to 45. Why do they break it down now? It's because when they start to get into 3B, you're going to see the metabolic consequences that require interventions. Stage 4, GFR is 15 to 30. That's when you bring in your nephrologist, if you've not done so before. Stage 5, the nephrologist starts to work with them in the dialysis unit or think about a transplant. Albuminuria, less than 30 is normal to mildly increased. 30 to 300, moderately increased, and over 300 is severely increased. How do you evaluate a patient for chronic kidney disease? Our laboratory evaluation a radiographic evaluation, and if need be, a kidney biopsy will help you determine what's going on and what to do with it. A lot of the lab tests you can do in your office. You can do your urine, you can do an estimated creatinine clearance, or protein excretion, either random or 24-hour. And of course, you want to get a CBC, a metabolic panel, look at calcium, phosphorus, and uric acid levels. If you send the patient to a nephrologist, they're also going to order a serum protein electrophoresis, hepatitis B, hepatitis C, and HIV studies, and ANA and complement studies. You can do all that in your office too. ANCAs and anti-GBM antibodies in the purview of the nephrologist. If you're going to do a radiographic study, we recommend an ultrasound as the safest one to do and probably the best place to start. CTs, MRIs carry some risk with chronic kidney disease, as do angiograms. The urologists usually do the cystourethograms. There you're expecting obstructive disease. Who gets a biopsy with chronic kidney disease? Persistent hematuria with low GFRs or persistent proteinuria, typically in the nephrotic range, over 3 grams a day, where you have an unknown cause for your CKD, kidneys are normal or large, or as I mentioned earlier, AKI is getting worse when we're thinking of using steroids or immunosuppressants. Contraindications to renal biopsies, if you should decide to do one in your office, which I know you're not. Bleeding tendency of coagulopathies. Don't biopsy small kidneys or a single functioning kidney. Don't biopsy in patients with severe hypertension who are obstructed, who are actively infected. And then the absolute contraindication, patients unwilling to give consent. The lawyers have a name for that. It's called assault and battery. Question number 2. Nephrogenic systemic fibrosis most often occurs as a result of which of the following? Chemotherapy with an alkylating agent, hemodialysis, peritoneal dialysis, or MRI with gadolinium contrast. Your vote is for D, and that's correct, an MRI with gadolinium contrast. How many of you have seen patients with NSF? 2, maybe. You got this one right. Family docs are pretty smart. So what is NSF? This happens in patients with advanced chronic kidney disease, stage 4 or 5, given MRIs with gadolinium contrast. The gadolinium is a cation. It binds to anions, forms precipitates, insoluble salts that deposit in tissues and initiate fibrosis. In the skin, you get plaques. In the joints, contractures, and in things like the liver, lung, muscles, and heart, which we know are pretty vital structures. If they had surgery or recent inflammation, more likely to have this happen. Dialysis doesn't help, even right after the gadolinium contrast is administered. So what you may see from the board is a question, which is safer in chronic kidney disease stage 4? An MRI with gadolinium or a CT with iodinated contrast? And the board will tell you it's the CT because if they can get in trouble, you can dialyze them. It's usually reversible, not necessarily the case for the MRI. How do you manage chronic kidney disease? You manage it based on the diagnosis specifically, if you know it. You work to slow loss of kidney function. You look at cardiovascular disease. That's what they'll die from. You prevent complications. Eventually, if they get into stage 4, then you work with your nephrologist to prepare them for dialysis or transplantation. You manage them by stages as well. Stage 1, again, you're really on slowing progression and treating comorbid conditions. Stage 2 as well, and you start to estimate their progression. Stage 3, particularly 3B, you're seeing complications to treat. Stage 4, they get the nephrologist, they get prepped for what's going to come. Stage 5 is dialysis or transplant. Patients are also part of the picture here. Self-management is important. If they have those diabetes, hypertensive risk factors, you manage that diabetes with them. They watch their blood pressure and avoid excess salt. Maintain nutrition. Get rid of those cigarettes. Exercise. Take your medicines. Always a good idea if they're good medicines. Monitor that GFR at least yearly, but more often if the patient gets to stage 3 or beyond, or the GFR is declining faster than you would normally suspect. Review all their medicines every time they come in. I mean, we do that all the time anyway, but particularly important with renal disease because you need to adjust your dose depending on your GFR for many medications. In managing your chronic kidney disease patient, there are some modalities, things that always seem to be coming up as renal disease progresses. So the KDOQI guidelines talk about managing hypertension, anemia, acidosis, hyperkalemia, metabolic bone disease, malnutrition, cardiovascular disease, and hyperlipidemia. And we're going to spend the rest of our time this morning with those particular subjects. So question number 3. Which of the following statements are true about CKD and hypertension? Most patients with elevated creatinine levels can be safely treated with ACEs or ARBs. JNC8, remember them, recommends a target BP of 130/90. KDOQI recommends a target blood pressure of 140/90. And hypertension and CKD is typically not responsive to diuretic therapy. Your answer is A, and that's correct. Most patients with elevated creatinines can be treated safely with an ACE or an ARB. In fact, when we first started using ACEs or ARBs, our nephrologist said, don't use ACEs or ARBs, patient with creatinine over 2. Then they said 4, then they said 8, then they stopped it altogether. So you can use it as long as the person's creatinines aren't jumping dramatically in an AKI setting. What about JNC8? JNC8, as Dr. Fernhaber told us, in general population, the target to start treatment is 140/90 if you're less than 60, 150/90 if you're over 60. JNC8 said chronic kidney disease start at 140/90, diabetes the same. What do we use to treat this with? As he mentioned, in chronic kidney disease, JNC8 says ACE or ARB. For African Americans, thiazides or CCBs. For Caucasians, thiazides, calcium channel blockers, ACE inhibitors, or ARBs. KDOQI, however, had some different recommendations, but these are older than JNC8. They said the target should be 130/80. Now, the reason we mention these discrepancies is that your nephrologist may be using KDOQI criteria. So if you hear different things from them than what you have heard, this is probably why. And KDOQI said that antihypertensive therapy should be used to lower pressure, reduce risk, and slow progression. If the board asks you a question on target, it's going to mention typically the group that recommends that target. So you don't have to worry and guess which group that they're trying to have you respond to. With KDOQI, you want to use the preferred agents for chronic kidney disease and hypertension, which is ACE or an ARB, particularly if the patient has diabetes or proteinuria. Diuretics should be included and other agents chosen based on specific cardiovascular disease indications. Use an ACE or an ARB if the patient has diabetic kidney disease, diabetes with chronic kidney disease, with or without hypertension. And in patients with non-diabetic kidney disease who have proteinuria with or without hypertension. Okay? ACEs and ARBs can be used safely in most patients, as we mentioned. Monitor, of course, different parameters, and your GFR is part of that, as your potassium is part of that, because there's a risk for hyperkalemia. Use them in moderate to high dose as alternatives to each other, but not together. Don't use them together. Most patients with chronic kidney disease should have a diuretic on board. If GFR is over 30, thiazides work. Less than 30, use a loop rather than a proximal tubule diuretic. You can use them together if a patient has volume overload. Be careful about potassium-sparing diuretics in chronic kidney disease because of hyperkalemia. Use long-acting agents rather than short-acting agents. If the initial blood pressure is very high, then you can start with 2 different agents. I've included in your handout the actual tables from the KDOQI. Question number 4. Which of the following is true regarding anemia in CKD? Packed red cell transfusion indicated for hemoglobin less than 10. A target hemoglobin, CKD4, receiving epigen is 13 for women, 14 for men. Most anemia in patients with chronic kidney disease is iron deficiency anemia, and treatment with a erythropoiesis-stimulating agent is associated with an increased risk of MI and thromboembolic events. Your vote is for D. D is correct. Therapy with erythropoiesis-stimulating agents does have an increased risk of MI and thromboembolic events. Anemia is very common with chronic kidney disease. You should do hemoglobin testing annually. Per KDOQI, 13.5 for men, 12.0 for women, indicates anemia in chronic kidney disease. If you evaluate these patients, do what we normally do, a CBC. Also, a retic count, a measurement of serum ferritin for iron stores, and an iron TIBC ratio. Most anemia in chronic kidney disease is anemia of chronic disease. You can identify those folks. Their ferritins are normal, their serum irons are low, their TIBCs are low, and the ratio is over 15%. As opposed to iron deficiency, where the ferritin is low, iron is low, but TIBC is high, and the ratio is less than 15%. Chronic kidney disease, probably the most common cause now of anemia of chronic disease. Acute and chronic infections, malignancies, malnutrition can also do that. How do you treat anemia of chronic disease? You treat the underlying cause if you can identify it. If it doesn't get better, use an erythropoiesis-stimulating agent. If they still are symptomatic after using that, then think about red cell transfusions. Erythropoietin is a glycoprotein growth factor made in the kidney when the kidney does not get enough oxygen. Either that's because the PO2 is too low or the hemoglobin is too low. Either one of those will do it. Erythropoietin-stimulating agents similar to erythropoietin are used to treat, again, anemia of chronic disease, be it from renal disease or from malignancy. Agents include darbepoetin and erythropoietin alpha. They're equally effective. For them to work, though, the iron stores need to be adequate. Ferritin must be over 100, saturation over 20%. There is a black box warning if you use these agents for increased mortality and serious events, such as MI and stroke. In tumor, progression may occur in cancer patients and thromboembolic events in surgical patients. And you don't use them if the patient has uncontrolled hypertension. Dialysis patients, target is about 11. You monitor the hemoglobin monthly, and again, make sure the ferritin and the saturation are adequate. What about transfusing them? Try to stay away from them if you can, because it sensitizes them against certain antigens, making it hard to get a transplant later. Target for epigen is not the same as a transfusion trigger. Question 5. Most common acid-base abnormality in CKD is which of the following? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. And you've not disappointed me. Metabolic acidosis is correct. Metabolic acidosis. In chronic kidney disease, metabolic acidosis is due to an increased anion gap acidosis because you do not excrete acid appropriately. Remember, mud piles, DKA, ketoacidosis, food alcoholism, lactic acidosis, salicylate and glycol poisoning cause metabolic acidosis with an increased anion gap. In patients with chronic kidney disease, we start to see that as the bicarb gets less than 22. Only 5% of the time you see that in CKD stages 1 and 2, but by the time you're up to 5, more than a quarter of patients are acidotic. And those who are tend to do worse in terms of their overall mortality. So the guidelines say try to maintain that CO2 over 22 on your Chem7. We do that with bicarb, Scholl solution, or sodium citrate, which is metabolized to bicarb. You can use calcium citrate, acetate, or carbonate as well. Question 6. Which of the following patterns commonly found in CKD? High calcium, low phosphate, high PTH. Low calcium, high phosphate, high PTH. High calcium, high phosphate, low PTH. Low calcium, high phosphate, low PTH. You voted for B, low calcium, high phosphate, high PTH. You know, we're doing really good here for chronic kidney disease. This brings the topic of metabolic bone disorders. You used to call this renal osteodystrophy, which is an older term. These are characterized, again, by abnormalities of calcium, phosphorus, PTH, vitamin D metabolism. You can see extracellular calcification. We have a patient in the hospital now with calciphylaxis in her vessels, ulcers, not doing very well. If you want to think of how this presents, remember secondary hyperparathyroidism. Started by low calcium, high phosphates, therefore high PTH. The guidelines suggest you measure calcium, phosphorus, and PTH once you get into stage 3 or below. You try to maintain that phosphate at a reasonable level, a little bit more leeway in the patient who's in CKD5. And how do we do it? We restrict their phosphorus. No Coca-Cola, which is phosphoric acid, takes the paint off your car and your kidneys. Use phosphate binders if you're not getting anywhere with dietary phosphorus restrictions. Those binders are calcium-containing, like calcium carbonate and calcium acetate, or non-calcium-containing, like sevelamer and lanthanum. Which ones do you use? Calcium-containing binders are cheaper. Patient's calcium is low, it's a probably reasonably good choice. If patient's calcium is normal to high, use a non-calcium-containing binder. Also, if they're on vitamin D, use a non-calcium-containing binder. Don't use Amphigel. We used that in the past. Aluminum, get aluminum toxicity with renal insufficiency. What about a parathyroidectomy? Only if they have a really, really high PTH and their treatment is refractory to medical therapy. Don't need to do bone x-rays in these patients. You don't need to do DEXA scans just because they have renal disease, but you can do DEXA scans for routine health maintenance. Nutrition guidelines. Dietary and therapeutic lifestyle modifications are recommended. Dietary sodium, less than 2.4 grams, is recommended. Dietitians can certainly help you in educating your patients. Number 7, according to 2013 KDO-QI guidelines, which of the following statements is true regarding lipid management in CKD? Fasting lipid panels should be done every year. Target LDL is less than 100. 21-year-old men with CKD and 10-year predicted risk of SCVD greater than 7.5% should get statins. Individuals over 50 with CKD and a GFR less than 60 should be given statins. What do you think? Your vote is for D. I'm sorry, your vote was for C. The correct answer is D. Individuals over 50 with CKD and GFR less than 60 should get statins. Okay. Dr. Fernhaber told us about the ACCHA lipid guidelines. Statins should be given per those guidelines to patients with established atherosclerotic cardiovascular disease like peripheral vascular disease or MIs or strokes, those who have an LDL of over 190, those who are 40 to 80 with LDLs 70 to 190 who are also diabetic or have a 10-year predicted risk of over 7.5%. That's ACC guidelines. KDIGO says if you're over 50 and you have chronic kidney disease, you basically get statins. If you have GFR over 60, you can use ezetimibe instead of a statin, but mostly statins. If you're 18 to 50 and you have chronic kidney disease, you get statins if you have known coronary disease, diabetes, a prior stroke, or a 10-year incidence of over 10%. So CKD, most of those patients will get statins per KDIGO guidelines. Renal transplant patients get statins. Dialysis patients, if they've been on it, continue it. If not, you don't have to start it. Somebody asked me last time why that is, and the guidelines don't say why. They just say that. If you have newly diagnosed chronic kidney disease, evaluate initially for dyslipidemia with a fasting lipid panel. After that, you don't have to continue to follow them. They should be looked at for possible secondary causes, including hypothyroidism, diabetes, alcohol abuse, liver disease, and some medications. What about diabetic nephropathy? We mentioned that before, a leading cause of end-stage renal disease. Look at microalbuminemia as a marker for that progression. So we should be doing that in all of our diabetic patients. Screen a microalbumin creatinine ratio at time of diagnosis for type 2 diabetes. With type 1, you can wait 1 to 5 years, but then they should be screened as well. Once you've confirmed and reaffirmed those abnormal results, it's not so important to keep on following it if it's high. If it's normal, then continue to follow it. We mentioned those values. Less than 30 is normal, 30 to 300, intermediate, over 300, macroalbuminuria. We delay progression by actively managing our diabetes, intensive blood glucose control, and blood pressure control. ACEs and ARBs are first line here, even if blood pressure is normal. It's an antiproteinuric effect. So use ACEs or ARBs in normopensive patients with diabetes who have albumins that are elevated or are at high risk for CKD or its progression. Don't use ACEs or ARBs to prevent CKD in diabetics who have normal blood pressure and diabetics who have no protein in the urine. That's a new recommendation over the past 3 to 4 years. Not every diabetic needs an ACE or an ARB, only if they're diabetic with hypertension or a diabetic with proteinuria. Reducing protein is helpful in reducing the risk. So again, who gets ACEs or ARBs? Diabetics with chronic kidney disease, albuminuria or a kidney clearance less than 60, or diabetics with hypertension, or patients with chronic kidney disease who have albuminuria or hypertension. Our last question, indications for nephrology referral in patients with CKD include which of the following? GFR less than 30, blood pressure over 130/80 despite an ACE and a diuretic, the presence of a new, recently trained, highly indebted nephrologist in town, or diabetes and a urine creatinine ratio of 30 to 300. And you voted for A, GFR less than 30, and that's correct. That new nephrologists have to get another job if they need to pay off their debts. So who goes to the nephrologist? Acute, complex, or severe cardiovascular disease, anemia of chronic kidney disease, bone and mineral disorders, can't manage their medicines, potassium is really high despite treatment, refractory proteinuria, resistant hypertension, stage 4 CKD, that's a take-home message here, unexplained GFR over 30% over 4 months. Your last slide, evidence-based guidelines, ACE or ARB in non-diabetic kidney disease who have proteinuria or diabetics with kidney disease. Concurrent use of ACEs and ARBs are avoided. Erythropoiesis stimulant agents, hemoglobin not above 11, and avoid gadolinium in stage 4 or 5 CKD. Here are your answers. We're done with the kidneys for today. I hope this is helpful.